Our next speaker is a colleague of mine at Ochsner MD Anderson. Dr. Ashely Staton is one of our lymphoma experts in our adult hematology group, and also our inpatient unit director for cell therapy and acute hematology. And is going to be talking today about a change in kind of the mindset of treatment of mantle cell lymphoma and the decline in the use of transplant in that lymphoma type.
Good afternoon. I think there's one more speaker between me and your crawfish boil, so we will try to keep this as close to on time as possible. Like Laura said, I'm Ashely Staton. I'm one of our BMT attendings at Ochsner, and we'll be talking about the decline of auto transplant in the mantle cell setting. I have no disclosures like Bob, but I would like to talk about mantle cell. If you think about the almost 200 subtypes of non-Hodgkin lymphoma, mantle cell is a relatively small percent, right about 6% of the overall breakdown of non-Hodgkin, but we see it frequently and we treat it relapse after relapse. So these patients will see multiple lines of therapy over their time course with us. Typical patient, we have about a 4-to-1 male to female ratio. Median age is in their 60s. About a third will have a leukemic phase. About a third will have B symptoms, which are your classic unintentional weight loss, night sweats, early satiety, lymphadenopathy. And then by far the most common extranodal site is the GI tract. About 80% of people actually have GI involvement, which is why colonoscopy, endoscopy so often is a part of our workup if they have any of those symptoms. What are the prognostic factors? It's pretty impressive when you look at the unfavorable, as you'll see with the multivariate analysis. So unfavorable patients have a high MIPI score. This is a modified version of the IPI. A high Ki-67, over 30% for mantle cell. You'll see different breakdowns of what's considered a high Ki-67 based on the type of lymphoma. I equate this for myself to how fast are those cells doubling. I take it all the way back to like early biology for my patients. And I was like, do you remember like the DNA, double, 2 new cells, double, 4 new cells. If someone has a 17p deletion and if someone is p53 mutated, to me those overwhelmingly will show an unfavorable status. As you can see, there was a multivariable analysis that showed patients who harbored a p53 mutation had a progression-free survival of 1 year versus 12.7. That's a substantial difference in timeline between survival. We'll come back to that number though later. So initial therapies in mantle cell vary quite differently. There's a small population that we can actually do watch and wait. That's an indolent subtype with a low Ki-67, low tumor burden, asymptomatic. That's only about 15% of patients. In my experience, that leads to my most second opinions if I tell someone, hey, you have lymphoma and we're gonna watch you. Then we have other initial therapies, often Rituxan plus high-dose cytarabine based. Whether we do transplant, this is a little bit older study, so we'll talk about that, or a bendamustine, HiDAC, plus minus acalabrutinib. And then we really start to look, is auto transplant needed, specifically in minimal residual disease negative after induction therapy? There's a whole trial on that. Or is auto transplant needed after BTK inhibitors are used in the upfront line therapy, which is triangle trial, which we'll also be speaking about. Always go back to NCCN guidelines, at least I do, and I look at my preferred intense regimens. These are in alphabetical order, so no particular preference despite what comes first in our alphabet. Lima regimen, which is our DHAP times 4 plus R-CHOP. You have the Nordic regimen. These are a little bit older therapies, but tried and true. It's a dose-intensified, what we call maxi-CHOP. You could have triangle regimen, which we'll look at the specific data a little bit later, where you're alternating R-CHOP plus a BTK inhibitor in our DHAP inpatient. And you'll see that that BTK inhibitor is, for the most part, ibrutinib. That's category 2A indication, but category 2B would be for acalabrutinib or zanubrutinib, or hyper-CVAD. Most patients are still seeing some form of maintenance therapy, whether it's after transplant or after induction regimen, an intensive one that we spoke of just now, where you'll see a BTK inhibitor used for about 2 years, or Rituxan every 8 weeks for 2 to 3 years. These are some randomized trials that I thought would be important looking back on how induction or the initial therapy has changed over the years, specifically since 2020. Since in 2022, the SHINE study looked at ibrutinib plus BR versus BR alone. As you can see, the progression-free survival is quite substantially different. With ibrutinib added to BR, PFS had 80.6 months versus BR alone, which was 52.9 months. While that progression-free survival is substantially different, so meaning time to next therapy, the overall survival in that really shook out to be about the same at about 55% at 7 years. Triangle trial is the one that's looking at whether we really need transplant in the setting of things like ibrutinib. And then finally, whether we would add bortezomib to BR versus BR alone. Bortezomib made really no difference whatsoever in our induction regimens. There are some ongoing trials for mantle cell that really look at adding newer agents, the BTK inhibitors, whether it's acalabrutinib, zanubrutinib. These are ongoing. So now we're looking at the advances in upfront therapy, whether it's optimizing the backbone of the chemotherapy we're using, adding targeted agents, redefining the role of transplant, and if we need it, improving maintenance regimens, and all of these are combined to improve the overall outcome in mantle cell. So redefining this role. Right now, there's a lot of mixed data on it. There are several retrospective studies that have addressed the issue, both in Europe and in North America. In North America, we had one group that demonstrated superior progression-free survival and overall survival in patients who underwent transplant. But in the real-world analysis of similar data, they showed low rates of autotransplant use without significant benefit in overall survival or time to next treatment, meaning next therapy line needed. What this really truly shows is that randomized prospective going forward data is needed to give us a definitive answer here. One study that was looking to do this was 4151, where we're assessing the benefit of autotransplant in MRD negative, so no circulating tumor DNA evident patients. Another one was Triangle trial. Triangle was looking at whether transplant, so there's 3 arms, where you have your control arm that everyone did go to transplant. You have your experimental arm where people went to transplant and had 2 years of maintenance of ibrutinib, or you had your second experimental arm where it was just the 2 years of maintenance of ibrutinib, no transplant. And early data there suggested that the inclusion of ibrutinib and the omission of transplant did not significantly impair failure-free survival and was associated with reduced toxicity. So similar to the earlier talks where we talked about the toxicity of the conditioning for transplant, that holds true for lymphoma patients as well. The overall survival at 3 years at least was fairly similar. So the transplant alone group, overall survival was 86%. Transplant and ibrutinib, 91%, and ibrutinib without transplant, 92%. While at that point, that data point, it was too early to evaluate statistical significance, trends started to become obvious. It's unclear at the moment whether the addition of the BTK inhibitor is responsible for the lack of benefit of transplant, or if transplant by itself is simply not beneficial. So what are these BTK inhibitors that we're talking about specifically in mantle cell? I continue to refer to ibrutinib because that was the one used in these studies. However, it's no longer FDA approved for indication in mantle cell. Newer generations, acalabrutinib is a second generation irreversible inhibitor. It has better selectivity and minimal off-target effects. The overall response rate was still quite impressive of 81% and a CR rate of 48%. Where zanubrutinib, another second generation, also irreversible inhibitor with a similar profile, an overall response rate of 84%, CR rate of 68%. One that I found notably different was pirtobrutinib. It's a reversible inhibitor, so it can bind and unbind. On the phase 1 study that looked at this, over 90% of those patients had been exposed to things like ibrutinib and acalabrutinib. And still, those patients had an overall response rate of 51%. This was a heavily pretreated group. Their CR rate was substantially lower, though, at 25%. And interestingly, BTK naive patients, so had never seen ibrutinib, Overall response rate was similar at 82%, but CR rate was quite dismal at only 18%. Of note, ibrutinib is still your preferred therapy when you're talking about CNS mantle cell, which I actually saw my first patient not too long ago. So looking at the newer agents, things that are most likely replacing or at least minimizing transplant, BiTE and CAR T therapy. BiTE therapy is a dose escalation. It's off the shelf. For the most part, it's outpatient. We do have to admit patients for small periods of time for the big ramp-ups to monitor for CRS, ICANS. Whereas CAR T is a one and done, where it's one infusion. However, they are in the hospital for about 2 weeks. It is considered a potential cure in lymphoma, less so in myeloma at the moment. But both therapies, I think, are playing an earlier and earlier role in mantle cell. So the two CAR T products that are currently FDA approved for mantle cell, one is Tecartus. It was FDA approved in 2020 based on ZUMA-2. And at median of 12 months, you had an overall response rate of 93%, which is your graft A, and a CR rate of 67%. At 6 months, almost 80% were MRD negative. But I find this particularly interesting. The overall response rate was more than 90% in P53 mutated patients. If we go back to the second or third slide and we saw that meta-analysis, P53 mutation had an overall survival of 1 year compared to 12.7 years for non-P53 mutated. So CAR T is showing to be very important in this patient population. Real-world evidence of Tecartus is a little bit less impressive. We have higher rates of CRS and ICANS than in ZUMA-2, and this is thought to be due to the higher disease burden and the longer time to CAR T infusion in real world, which is still a factor. The trials run beautifully, infusion times are minimal, and we're all still working to reduce that time because data shows significant improvement for at least under 30-day infusion. Oops. The second one was Breyanzi, FDA approved in May of last year based on the Transcendent trial. And it shows fairly similar data with at 6-month follow-up, overall response rate of 84% and a CR of 59%. Of note, this group also had very high efficacy in patients with high-risk features. And last topic of the thing is, what are BiTEs, bispecific T-cell engagers? We see BiTE therapy in multiple myeloma. We see it in lymphoma. The concept first appeared in the early 1960s, and the first example was constructed in 1985. BiTEs activate T cells without the need for co-stimulation, which we're not going to go too much into the biology of it, but that is in stark contrast to CAR T therapy. It preferentially activates memory T cells, and they do not activate other immune cells like macrophages, neutrophils, and natural killer cells. So you would expect less CRS, less ICANS in this patient population. One of the BiTE therapies that we commonly use for mantle cell is glofitinib. Of the original study, the median follow-up time was 8 months. But as you can see, the median time to response for these patients was 51 days. This is a big problem when you're thinking about patients who have rapidly progressive disease. BiTE's off the shelf, so we don't have the delay like CAR T and engineering. But almost 2 months till any response is a hard thing to sell to patients when they know their lymphoma is blowing up. Interestingly, there was no progressive disease that was reported in this patient group. So the take-home points for this are risk-adaptive management is necessary in this patient population. The role of autotransplant for younger patients is in doubt at this point, but more prospective studies are ongoing and needed. The standard of care is likely moving away from autotransplant, as we can see as the triangle trial data matures further. Durable responses in relapsed refractory mantle cell with CAR T, particularly if a CR is achieved. BiTEs are showing promise activity in this disease space, and chemo-free regimens are promising as a frontline therapy to help reduce the intensity of that induction. Any questions?